May I request Dr. Anil Handu to chair the session for Dr. Ramon?
Good afternoon, everybody. It's my proud privilege to introduce Dr. Ramon Lopez. In fact, we have already introduced him in the last session that was yesterday. He is a clinician and a laboratory hematologist at the same time and has extensive work experience on hematology analyzers. And even currently, just about an hour back, he was actually looking at how will we have more studies on hematology analyzers, and I'm sure he's going to share with us something very insightful about chronic disease. All yours, sir.
Thank you. Yeah, anemia of chronic disease is a challenge for me, and this is the reason I was interested in to talk about that, because in my experience, it's the anemia that has less diagnosis or wrong diagnosis in the clinical practice. Because many GPs, when they have low iron, anemia, they give iron. If doesn't respond, more iron. Vitamin C. If doesn't respond, intravenous iron. Finally, when they don't respond, they do the ferritin. And the ferritin is 100 by 100, and the CRP is high. And they realize that, in this case, they send to the hematologist. But it is a big problem. And I think it's a challenge, and we have to try to help the GPs to understand this anemia. First, let me define what is anemia. And I will remember again, because the WHO criteria for anemia is old, and we have found that many latent iron deficiencies, ladies that are working, some men, but ladies that are working, but have an hemoglobin of 12.2, 12.3, they have ferritin lower than 15. And they will develop anemia in the next months. But the criteria really has to be higher. And I recommend to use the WHO criteria that says that the criteria for anemia in men is less than 13.7 or less than 13.2 if you are more than 60. And for the ladies, less than 50, 12.2, less than 12.2, and not less than 12. Okay? And you can investigate that. You can investigate persons that are with 12, do the panel, the anemia panel, and you will find that many of them have a latent deficiency. And in the blacks, it's lower values, genetically, historically, or also maybe because they are protected historically from the malaria. The WHO did an experiment in Africa supplementing iron to all the people, and they got a lot of malaria deaths because iron deficiency protects from malaria. The experiment went wrong. Many people died because systematic administration of iron, oral iron in the food. I divided the anemia in the more common causes. And as we can see, iron deficiency anemia is 37% of the diagnosis of anemia. In a general population, the anemia of chronic disease is 27%, but this is not happening in the hospital setting. I did a study, and I recommend you to do, with 1,000 patients, randomly selected, no any criteria, only anemia, and I did to all of them B12, folate, CRP, iron, transferrin, ferritin, and I discovered that the leader was the anemia of chronic disease. When you do a systematic approach and you use the criteria that transferrin has to be normal or low, ferritin has to be high, normal or high, you do all the criteria, you find that is the leader in causes of anemia. But let's begin with anemia. Of course, first is the blood smear examination. We try to get the best from the instrument. But yes, because we don't want to miss any abnormal case. But for me, the microscope is mandatory. I have 3 microscopes in my home. For this reason, I love microscopy. And the basis diagnosis for anemia, the first time you have to do a red blood cell morphology, moreover in cases with no clear diagnosis. And of course, when you see some of that you all recognize that, you have the diagnosis. Why to investigate more? You have the reason for the anemia, and that is mandatory to do it. I obtained these slides from Dr. Juan Luis Vives Corrons, one of the best experts in anemia and hemoglobinopathies in the world. He passed away last summer, not this summer, the previous one. And he is my friend, even if he is not with us anymore. And I did this for everybody, that to teach all the people how to recognize the different type of red cells. Okay? I don't need to enter on that, but you will keep it and will be recorded in the video for teaching purposes. Okay, and how we can diagnose the iron deficiency anemia? I will go very fast if we don't need to. Low MCV for sure. Okay, higher DW is the best parameter alone to screen for anemia, a part of the research part of the CHR, hypochromic, but is the best parameter from the CBC to identify the anemia. The RDW is in a specific, low MCHC, red blood cells, RHE, reticulocyte hemoglobin for sure, and that is important because in these cases of latent iron deficiency, you find maybe the volume is still 80, 79, 81, but the reticulocyte hemoglobin is low. The new reticulocytes that are produced have hypochromia, but all the other not, because we have the average of 120 days. I am going to go fast because I want to spend my time. Of course, there are discrimination factors from England Fraser to differentiate thalassemia and iron deficiency. Of course, CRP has to be negative, and I insist that. Please take home message. You cannot diagnose except in a lady that is healthy, bleeding, with metrorrhagias, but in all the rest of anemias, you cannot do a diagnosis of iron deficiency anemia without ferritin, or you don't have ferritin with a CRP that is negative, or inflammation markers like ESR, or other inflammation markers. You have to have a marker, a negative marker of inflammation. This is the important take message from this talk. Second, more frequent, and now is the time for my talk, but I am obligated to talk about iron deficiency because we are going to compare them. The MCV is normal, okay? But in 67% of the cases. In another 16.7 is a low. And we need to know that, okay? And another 16.5% is high. For this reason, we can have the three. Low MCV, don't exclude the opposite. Have a big possibility, about 17% to have anemia of chronic disease. And I will recommend to see this plot. This plot and this article from New England Journal of Medicine, from Gunther Weiss, is the Bible of the anemia of chronic disease. It's becoming old, but it's still an article that we need to read, all of us. Please read it. Because also talk about ferritin. Ferritin more than 100, you begin to have a higher risk of infections. The reason the reference values of 300 are not true. They are 300 because the more common genetic disorder is hemochromatosis. And even you have a heterozygous hemochromatosis, you have a higher ferritin than 100. I did a study, random again, in women with hemoglobin between 12 and 13. And I did ferritin to all of them. All the ferritins more than 100, I did a study of hemochromatosis. 90% of these ladies have a gene of hemochromatosis when the ferritin was more than 100. Ferritin more than 100 is not normal, except if you have a liver disease, or you are alcoholic, or you have any other risk factor for that. But this is important because, as you can see, the differential diagnosis of iron metabolism disturbance, and now I am going to go for my stick, it's a biochemical marker of inflammation, is the first thing you need to do. And this is from New England Journal of Medicine, and this is from Gunther Weiss, recognized, is invited to the ASH meeting to give talks about anemia, is one of the more ethical and knowledgeable persons about anemia. The first is CRP. Not iron, not any other thing. CRP or any inflammation marker. Okay, after transferrin saturation, and after ferritin. Less than 30, less than 30. I have seen reference values in many labs, 17, less than 17, less than 20, less than 12. No. You are including latent iron deficiencies in your reference values. No, are 25 or even 30, depending the laboratory, but never 12, never 15, never 17. And you divide the iron deficiency less than 30 ferritin between 30 and 100, anemia of coronary disease, and there is another option that is, anemia of coronary disease, and there is another option is the mixed anemia of coronary disease with iron deficiency. For example, a colon cancer. You are bleeding, you have a cancer, you have your iron blocked, and and finally you have also at the end a low ferritin. But you are giving iron and they only increase the ferritin. Only increase the ferritin. The serum iron begins the same and the hemoglobin begins the same because you have lost all the deposits because the constant bleeding in the colon. And that is something that I recommend you to check. Here is the soluble transferrin receptor divided by the logarithm of ferritin. I am sorry, but I am against this parameter. Why? Divide the glucose of the patient or creatinine with logarithm of ferritin will be good for anemia of coronary disease. When you divide something by the logarithm of ferritin, even you can choose the creatinine. You will have a good diagnosis of anemia. But it's the ferritin what is important, not the soluble transferrin receptor. Soluble transferrin receptor is normal in anemia of coronary disease and is normal in the iron deficiency anemia. When you divide it by logarithm of ferritin, it's useful, but it's a trick, it's a statistical trick. First thing I will destroy in my presentation, the coefficient. You have to do the transferrin receptor in the red cells. Yes, in the erythroblast. There you can measure with CD70, and this is useful, the receptor in the erythroblast. What happened? In the anemia of coronary disease, there is an increase of transferrin receptor, but there is a decrease of NRBCs and retics. At the end, it's normal. You have an increase of the receptors per cell, but the soluble is normal because you have the tumor necrosis factor make that the total number of erythroid precursors is low. At the end is normal. Normal retics, low or normal retic absolute number. High IRF, not in all the cases, but this is called ineffective erythropoiesis. Okay, and there is an increase of tumor necrosis factor, and there is that is what we found, and this is very useful. CRP, for sure, or IL-6. That is even better. IL-6, as we will see in the graph from Gunther Weiss, is the precursor of epsilon. Epsilon is very difficult to measure. The urine is the best, but IL-6 is available. And IL-6 is the best parameter for inflammatory, better than CRP. Red hemoglobin, for sure. Hypo-RBC, that are both high in iron deficiency anemia, in anemia of coronary disease. There is a low functional iron deficiency. Yes, but the ferritin will be normal or high. Okay? Soluble transferrin receptor is normal. Transferrin, this is very important again. Transferrin is normal or low, and that is very helpful. Transferrin is fantastic to diagnose anemia of coronary disease because will be normal or low. CRP or IL-6 will be high, and ferritin will be normal or high. Pathophysiology, the article from Gunther Weiss. This is the best graph about iron metabolism. What happens when there are bacteria, okay, when there is cancer, when there is inflammation? That the liver provokes, here we have interleukin-6. Interleukin-6 go to the liver and produce epsilon. Epsilon close the release of iron from the macrophages. It makes that the iron is all the iron that is available in the transferrin, in the blood, is accumulated in form of ferritin. And why? Why? Our body is doing that. Why? Our body provokes low iron, low transferrin saturation. Why? Because iron is very toxic in inflammation. Adds a lot of oxidation processes. Iron is very bad for the cancer. Cancer loves iron. Infections, bacteria loves iron. And our body is very intelligent and puts the iron in a safe place during the process, during the infection, during the inflammation, or during the cancer. If we insist and to give iron to this patient, we are putting wood to the fire of the cancer. We are putting wood to the fire to the infection, and we are going to put to the fire to the inflammation and creating superoxide radicals that will have damaged the heart, the arteries, will provoke a lot of side effects. Okay? Iron is bad in these cases, and the body is very intelligent. Listen to our body. And these are the pathways. Here I enlarge that. You know, the ferroportin is closed in case of the epsidin comes from the IL-6 epsidin. The ferroportin is closed. The ferroportin is the door that permits the release of iron. And also the iron is absorbed from the serum to the macrophage. And the macrophage keeps the iron in a safe place that is not damaging us. I will show you a very interesting article that was not made for my purpose, but is very useful for my purpose. Dr. Gunther Weiss gave me a visit from me to Austria, to Innsbruck, where he is working. And I need the stick for that. This was a study in hemodialysis patients. He chose similar groups. A group in hemodialysis that he was going to give erythropoietin and iron, and a group of hemodialysis with only erythropoietin, no iron, to see what happens. Both have similar age, both have similar ferritin, 300, okay? Both were very similar. And look what's happening. He was investigating how the iron affects all the interleukins and the POX and how it was affecting the iron. And here you can see the group of 0, no iron, and the group of 1, iron. The more amazing for him, look, the group with no iron, the ferritin was decreasing during the time till 160. The group with iron, with establishing the dosage exactly how the Kadoki said, was increasing with the time till 556. But look, the hemoglobin in both groups, 12, 12, 12, 12, 12, 12, 12, 12, 12, 12, with no any significant difference. In this case, why we need iron? We don't need iron if the ferritin is more than 150. Only erythropoietin. And that is the lesson we learn. We don't need, even if the transferrin is low, because believe me, look, the transferrin saturation in the group of no iron is increasing. You know, in the group of no iron is 18. In the group of iron is 38. You know, here, you know, the transferrin saturation shows that there is a lack of iron, but the hemoglobin is the same. Why? Something that was discovered after that, erythroferon. The erythropoietin, due to erythroferon, EFE, is able to liberate the iron by itself from the macrophage. The erythropoietin, thanks to the erythroferon, is liberating the iron it needs for erythropoiesis, and you don't need to give intravenous iron. And the group without iron, for 3 months, was keeping the same hemoglobin. The article of Gunther Weiss compared the anemia of chronic disease and iron deficiency. Look, iron, reduced, transferrin, reduced, increase in iron deficiency. This is an important point. But transferrin saturation, reduced. What the GPs do? Low iron, low transferrin saturation, iron. We need to convince them to do an inflammation marker every time we have an iron deficiency, first time. Okay? Cytokine levels, IL-6, increase and normal. And that is the schematics for the diagnosis of anemia. I recommend you to have a look in this article from the New England Journal of Medicine. The treatment of the iron deficiency of the anemia of chronic disease, the treatment of the underlying disease. If it's less than 7 the hemoglobin, transfusion. But never give iron. The patient have iron. In my experience, you can give as much iron as you want. The serum iron will be low. The transferrin saturation will be low. Only will begin serum iron and transferrin saturation when you are arriving to levels of 800 of ferritin, 700. Till this moment, it's still the same because the body is putting all the iron you are administrating to the macrophages. This is the study showing the erythroferon contributes to the recovery of anemia of inflammation. And erythropoietin liberates erythroferon. This is the way to liberate the iron. Only give erythropoietin in hemodialysis or in any situation except in tumors, because some articles have said that solid tumors, erythropoietin can stimulate the growth of the tumor, That was famous and is not indicated if you don't know if it's stimulating the growth of the tumor. And that is published in Blood in 2014. Another very important article that destroys the concept that I have heard many times, that says that the ferritin is an inflammatory protein. Okay? And everybody mentioned, yes, it's an inflammatory protein, but without iron. I was reviewing all the references, and finally all arrived to Carlo Brugnara from the Children's Hospital in Boston. Okay? He never showed any proof of that. He said, and everybody repeated, Auerbach, all the popes of hematology, but nobody demonstrated never that the patient with high ferritin don't have iron. But Gunther Weiss and Dr. Hall, in this article, they demonstrated the opposite. You cannot do a biopsy because nobody will authorize you to give biopsy to a hemodialysis patient. But they did another method. They were sorting monocytes from the blood in anemia of coronary disease, and they were measuring with atomic absorption the iron of the monocytes. And they have demonstrated that in anemia of coronary disease, the iron was very high in the monocytes of the anemia of coronary disease and not in the control group. The ferritin correlates with iron. After that, I was going to Dr. Razmilevich, famous doctor, passed away. But in this time, after one speech in the ASH about myelodysplastic syndromes and the treatment of anemia and erythropoiesis, I was challenging him to demonstrate my theory. We were putting in the table $100. Who is right, me or Brugnara and Auerbach? And he did the study in his hospital in Israel. He was following Brugnara. Every transferrin saturation low, every hypochromic red cells or CHR, intravenous iron and intravenous iron. Look what happened, and I was participating in this study, as you see. Look the patient how they were. 6,800 ferritin, 5,500. He was shocked when he saw that. They were not controlling ferritin because they said it's an inflammatory protein. It's useless. Don't contain iron. Okay. We were looking the patients, repeating the study of Weiss. The patients only with erythropoietin, with no iron, the ferritin was decreasing with normal hemoglobin. During 1 year, they become normals of ferritin. All the patients that have very high ferritin. During 1 year, only erythropoietin, and it was working. Okay, and here the T2 star demonstrating the iron overload in all of them. It was iron overload, similar than sickle cell anemia with multiple transfusions. And we have the test. We were checking the T2 star, demonstrating that the T2 analysis shows an accumulation in the liver, in the spleen, and in the pancreas. This ferritin contains iron, my God. But this lie, sorry, it was a lie because never was demonstrated that the ferritin is an inflammatory and don't contain iron is not true. For hemodialysis, we only need to keep the ferritin more than 150. That's all. Give iron when the ferritin goes down of 150. Doing that, you will keep the hemoglobin normal. Give the folic acid because they need folic, they need other things, but don't give iron to the anemia of coronary disease, even in hemodialysis. How to utilize the different tests in the anemia differential diagnosis? I will pass very fast because my time is up. I was using in this study of 1,000 patients all the hematological parameters. And in anemia of coronary disease, as you can see, nothing was high, nothing was low, was not useful. In iron deficiency, yes. Their DW was very high. In using the reticulocyte parameters, in anemia of coronary disease, we only see a high IRF. That's all. That's all. Okay? The retic percentage normal, but this is useful. This is called inefficient erythropoiesis. The only thing that is useful. And finally, I decided to use CRP and ferritin here. Here, I have a difference. Here, I have a difference. We don't have to divorce from the immunochemistry. They are our friends. We have to work together. We are better together. IL-6, ferritin, transferrin, CRP, why not? We don't have to do everything ourselves. We need to flag, we need to forward, to reflex, but we need them. We can assess the functional iron deficiency, yes. We don't have iron available, yes. Hypochromic red cells, CHR, perfect. But we need to do an inflammation marker and we need to check immunochemistry. Summary. It shows iron deficiency, erythropoiesis, just a few days. You know, I will go. This is a summary of the parameters. I will go. Okay, important. Summary. For iron deficiency anemia, MHCV is low, hypo-RBC is high, soluble transferrin receptor is high, reticulocyte hemoglobin is low, discrimination factor differentiated from thalassemia, and CRP is negative. Okay? Anemia of chronic disease, reticulocyte hemoglobin low, similar to that. Ferritin is, sorry, this is a mistake. Sorry. High or normal, a mistake. And CRP, IL-6 is high. And that is the important thing. Thank you. Any question?
Interesting presentation, and you have tried to explain to us the intricacies of the mechanisms that are interplaying in a patient of anemia of chronic disorder, and which component is contributing in what way is also that you try to touch upon. Which of these parameters or components or mechanisms is operating at a given point in time is also something which you highlighted. My question is, you did mention about anemia of chronic disorder with iron deficiency. I have done some studies in that area as well, and what I found is that patients who have coexistent iron deficiency in anemia of chronic disorders have higher serum transferrin, soluble serum transferrin receptor than the ones which are not having iron deficiency. So what is your, you did refer to that. Do you therefore suggest that this can be taken on face value, and the patients who show high transferrin receptor, patients of ACD showing high transferrin receptor would benefit from some kind of therapy, additional management which will supplement the iron while you are treating the anemia of chronic disorder?
To supplement the iron in anemia of chronic disease?
No, with iron deficiency.
Or with iron deficiency? Anemia of chronic disease with iron deficiency. It's the same. Normally, the only difference of anemia of chronic disease with iron deficiency and anemia of chronic disease is that the patient has lost, for any reason, iron. Yes. Normally it's a bleeding, and but the situation is the same. There is a cancer, or an inflammation, or an infection. Yeah. And in the three situations, the iron is toxic for us. For this reason, in this case, we need to, as is recommended, treat the cause of the problem. We need to treat the infection, the inflammation, or the cancer.
But not interfere with the...
We can give erythropoietin alone, but except in cancer, because it has demonstrated that in solid tumors, erythropoietin can increase the growth of the cancer. It's not a specific erythropoietin for red cells. It also looks like solid tumors have a receptor of the erythropoietin. The more important is it's very simple. Every time we detect iron deficiency, with all these parameters, immediate with reticulocyte hemoglobin, at the long time with low MCV, hypochromia, low MCHC, in any way, please, it's a simple CRP, sedimentation rate. And if you want to do it better, IL-6, because it's the precursor of hepcidin, and I recommend to do IL-6. But don't do anything else till you have an inflammation marker. With a positive inflammation marker, you are obligated to do ferritin, and you are obligated to do transferrin. And reticulocytes, because you have also see if there is an ineffective erythropoiesis. But the take-home message is never diagnose anymore an iron deficiency without a negative inflammation marker. Never more. Because that is, in my opinion, a big problem in hematology today. Not for you that you are expert, but the GPs, we need to activate always when there is an iron deficiency, first time, inflammation marker.
In patients of chronic renal disease, it's a big challenge. Renal patients,
Yes.
renal failure, patients who are on repeated dialysis. Assessing their iron status is also very problematic because serum iron will be low, transferrin saturation low. Ferritin may not be very high, but what would be your cutoff for ferritin?
150.
How much?
Between 150 and 250, that's all.
That's it. So if it crosses 100 and 200, then would you recommend iron in such cases?
No, and this is demonstrated in several studies now. Because now other groups in France are doing, but we have against the FDA. FDA only reimburse erythropoietin if you give intravenous iron together.
Yes, that is the point.
I know,
because they don't give erythropoietin.
I know.
They give iron with it.
I know.
Now, if we report the ferritin high, then they wait till the ferritin comes down with EPO. Otherwise, they give iron with EPO. Now, the challenge is, what is the level of transferrin saturation, or should the transferrin soluble receptor be done? Do you think, will it help us?
Soluble transferrin receptor is useful only when you are having a DAP of a mixed anemia of coronary disease and iron deficiency.
And iron deficiency.
When you have a high CRP and the ferritin is borderline 25, not low, not high, there you can do soluble receptor, okay? But I will never divide by logarithm of ferritin. I will divide by the absolute number of retics, as somebody proposed here to divide something by the retics. I don't know, remember which parameter, but this was the ideal, not by ferritin. Okay. If you divide creatinine by ferritin, will be useful for anemia of coronary disease.
Okay.
And the lesson is, yes, every hemodialysis patient, you have to give EPO and only keep the ferritin between 150 and 200, 250. But if it's possible to keep it between 150 and 200, remember that Dr. Turl said that more than 100, you begin to have an increase of infections, statistically significant. Right. Therefore, the reason is better to have the ferritin lower than 200, but 6,000. These patients have diabetes related to the hemochromatosis. Right. They have a lot of side effects, infections, death. How many deaths, people? Because this lie of the ferritin is an inflammatory protein. I agree. It increases with inflammation, but contains iron. Yeah. And now it's demonstrated.
So only if the ferritin is less than 100.
Less than
with EPO, then you give iron. Is that right?
No, we need to give iron to keep ferritin between 100 or 150, better, you have margin, between 150 and 250. Only keeping that. When it's more than 250, stop iron.
Agreed. Okay.
This is my recommendation.
But
and now,
EPO can be continued. EPO.
EPO always.
Can be continued.
EPO always, because the kidney is not producing any more EPO.
Yeah. Thank you. Thank you.
Oops, my stick. That was something to clean the floor.
Again, in chronic kidney disease, we tend to do a lot of bone marrow and they tend to be hypocellular. They are on EPO, but if we see the iron content in the bone marrow is 0, grade 0, no storage iron, then I guess in that case, iron should be given even if the ferritin is very high.
You know, the same value of ferritin is bone marrow biopsy.
Because most of these cases we have seen ferritin is very high. Sometimes more than 1,000.
If the ferritin is very high and you say in the bone marrow is low,
yes,
storage
iron is 0.
I never seen that.
Okay.
I never seen that. If you have one case, please give me, because I will investigate that. I never seen a case with high ferritin and no iron in the bone marrow.
Okay.
If you have it, please share with me, because that will make me begin another study demonstrating that. I never seen that.
Okay.
If you see that, please share to me.
Sure. Thank you.
Yeah, we need facts.
Ferritin being an acute phase reactant, it will rise first in the serum, as we understand, before it is stored in the bone marrow. Am I right to interpret it like that?
You know, what I believe is every time that the ferritin is high, we have to find with the pearls stain iron in the bone marrow. If not, we need to investigate that there is a mistake in the stain or anything, but we need to investigate it because according to this theory, and it's supported not only me, Dr. Hall, now very groups of French people, Dr. Toll, Dr. Hall, Dr. Gunther Weiss, that ferritin is always coming with iron. High ferritin is always coming with iron. If anybody finds the opposite, please contact me because we will investigate why, and we have other techniques to see if there is iron in the monocytes or iron in the macrophages with other techniques. But please share with me if you find any case.
We would like to look at that because
Absolutely.
once the serum ferritin is high, we don't do a bone marrow.
No?
Normally in these patients, unless you're suspecting some cause for renal failure like myeloma or anything else, we don't do a bone marrow. But she's right, in patients who are not responding to EPO, erythropoietin, they ask for a bone marrow.
No, yes, it's true.
Yes.
Because can have other reasons, other causes.
Yes.
But I never found with high ferritin no iron in the bone marrow. I never.
I think we'll start looking at high ferritin and do a bone marrow in those patients. Let's see what we can find. Good food for thought.
Very good.